yeah, I can show you later.
Okay, at this point, we'll move to the public comments. We have 3 public commenters, and we'll begin with Tracy Berna. I'll remind everyone that we do only have 5 minutes for public comments. Celia will be timing that, and you've already disclosed your conflicts or lack thereof.
I will talk very quickly. Thank you. Is that better? Okay. Does my 5 start now? What I'd like to impart on all of you today is the lived patient experience. I would like you to understand just how vulnerable endometriosis patients are, how much physical and emotional pain the disease causes, and just how desperate we are to feel better. It is necessary to understand the patient experience to truly appreciate the great responsibility we all have today, the weight of our decisions, and how these decisions will likely impact not only this generation of individuals who suffer, but future generations to come, like my daughters. Today, I not only represent my own experiences as a patient and a patient advocate, but I also speak for a patient community that has been historically silenced and underrepresented. And I thank ICER for including myself and Heather in these conversations surrounding elagolix, a drug that, if approved, will most certainly impact endometriosis care. Before I was able to access quality care, I, like many patients, spent well over a decade suffering unfathomable symptoms. Vital functions that healthy people take for granted were uncomfortable at best, but often unbearably painful. Doctor after doctor dismissed me, tests were inconclusive. For well over a decade, my physical, social, professional, and emotional well-being was compromised as I passed through many doctors, none of whom had the tools to diagnose me nor adequately treat my disease. Right before I found my endometriosis specialist, I went to a local doctor who claimed to be a specialist. I stepped into her office and immediately started crying. I told her that I no longer could sleep through the night as I had to urinate every 2 hours. I told her that when I had a bowel movement, it felt like my rectum was being ripped apart. I told her that I no longer could have intercourse with my husband as it was too painful. I told her that I was too fatigued and too sick to take care of my baby, a baby that I had fought so hard to have. I told her that I was absolutely desperate to find a better quality of life, and that I had heard that excision surgery and other complementary medicines could help me. She looked at me and told me that she would have to put me on Lupron for a year to verify if my symptoms were really endometriosis. If I felt better on Lupron, then it probably was endometriosis, and maybe then she would think about operating. I was upset by her answer. While I didn't look sick, my body was in crisis, and I was desperate, vulnerable, and I felt hopeless. I was 30 years old, and I had already been suffering for half of my life. My fertility doctor assured me that if he could just get me pregnant again, my problems would be solved. At this point, I had endured 4 miscarriages and 3 failed IVFs. Thanks to patient education groups, I knew that neither Lupron or pregnancy could treat my disease. I eventually found a true specialist who was able to excise disease off of every implicated organ and introduced me to multidisciplinary care. He provided me with the tools that I needed to thrive and ultimately transform my life. Looking back, it's hard not to think, what if I had been introduced to an endometriosis specialist when I was a teenager, presenting with period pain? No patient should feel the level of vulnerability and desperation that I felt. Doctors, medical organizations, and healthcare advocates have a responsibility to protect those who are vulnerable. Today we are discussing an important question. Is elagolix a useful tool for doctors and patients in the treatment of endometriosis? Patient advocates and healthcare providers are aligned in that both parties are overwhelmed by endometriosis and eager to have more tools to treat the disease. I have a daughter named Grace who is currently 10 years old, and I'm already worried that she may be presenting with early symptoms indicative of endometriosis. When reading about treatments, I often think about, would I want this for my Grace? I have read that the hope is that for elagolix to be especially beneficial for patients who have failed the first line of medical treatment, such as NSAIDs and birth control. We understand the benefits of birth control and NSAIDs for first-line treatment. The side effects are well-researched and for most patients do not cause harm. When endometriosis patients are given the first line of medical treatment, they have already presented with pain and have having quality of life issues. Endometriosis is already impacting their organs and vital functions. When birth control and NSAIDs no longer work, patients go back to their doctor again, often in desperation, as endometriosis causes even more fibrosis and inflammation, further implicating organs. If those stop working or Grace couldn't take them, I would want to refer to a specialist that has more tools. I would want her gynecologist to be able to recognize endometriosis symptoms and understand the benefits of multidisciplinary care, such as diet and pelvic floor therapy. These are effective tools with no adverse side effects. Today we're asking if it is helpful to give elagolix to these patients in crisis, knowing at best this medicine can only temporarily relieve symptoms. Truthfully, there's so much we don't know about elagolix. What we do know is that it's not like chemotherapy and that it doesn't eradicate endometriosis. It does not cure, treat, or stop the growth of the disease. Like birth control NSAIDs, it is palliative in nature and may reduce symptoms for some patients. We do know that it could be taken, well, it's only been shown research for a short amount of time, 6 months, maybe a year, but there's so much to learn about the long-term side effects of taking this drug. We know the long-term side effects for Lupron and other GnRH agonists, and they are not favorable. In fact, they can be quite harmful and last long after the patient stops taking the drug. And the favorable things that have been published about it, including the research findings, have all been said and done by paid AbbVie consultants, often in journals that take funding from AbbVie. Some of the leading endometriosis thought leaders and academics that are in favor of this drug are paid AbbVie consultants or work for hospitals that take large sums of money from AbbVie. But the question remains, is it a tool that will be beneficial to patients? How do we reconcile the fact that doctors and medical orgs are excited about it and so confident in a drug that we still have so much to learn about? I'm guessing it's because the majority of them will never have to take it themselves. What if endometriosis impacted men? What if endometriosis existed in the penis, the urethra, the scrotum, and throughout a man's entire pelvis, causing sexual dysfunction and impacted their ability to have children and work? How would they feel about a new and exciting drug that made them feel like they were in menopause, that didn't have clear answers in respect to long-term effects, just to possibly temporarily alleviate symptoms? Would they want more from their providers and medical organizations? Would they demand better from pharma innovators, reject clear conflicts of interest, demand informed consent? Would they be satisfied? If a drug has invasive side effects, I want it to at least eradicate some of the disease, not be a temporary solution. And I want the benefits of the treatment to at least last longer than the side effects themselves. I don't want an oral version of a drug that was so harmful to so many patients. I want the drug to be studied by researchers who have no conflicts of interest. I want providers and medical orgs who decide on treatments not to be allowed to take money from drug companies, so patients can be certain that their recommended care has only to do with unbiased, evidence-based medicine. Before providers are sold on any treatment option for patients, I want them to have the knowledge of more tools that have less side effects and referrals to experts in endometriosis care. Every day I speak to patients who have endured years of inadequate treatments. These temporary fixes have only led to continued pain and suffering. The less privileged, the less educated, the less savvy, the more likely the patients will be destined to a lifetime of suffering. AbbVie has spent millions to make sure that elagolix succeeds and will most likely make billions from this drug. My job is to make sure that patients succeed, and I'm worried what the physical and financial cost of this drug will be for endometriosis patients, especially for those most vulnerable. Thank you.
Thank you. Our next comment is Martin Robbins.
Five minutes.
You, to disclose any conflicts
Yes.
of interest and
Okay.
to restrict your comments to 5 minutes. Thank you.
Right. No disclosures. Treatment effects stopping at 3 to 6 months does not apply to excision therapy, surgery. Good afternoon. I want to thank ICER for allowing me to say a few words regarding endometriosis and elagolix. My name is Dr. Martin Robbins. My practice is the New England Center for Endometriosis. I'm 35 years in practice and have been specializing in laparoscopic excision for over 22 years. I have no direct experience with elagolix, but I have years of experience with the anti-gonadotropin Lupron. When tissue similar to the uterine lining is found outside the uterus in the abdominal cavity, that's endometriosis. Some people have children easily, others are infertile. Endometriosis can be found to be the causative factor in up to 40% of cases of otherwise unexplained infertility. Patients can have menstrual pain, pain with intercourse, chronic abdominal, pelvic, back, hip, groin, leg pain, and this is benign but locally invasive, and if you give it a chance, it will invade the intestines and grow through the urinary tract. Oncologists will say that endometriosis is not cancer, but this is a serious medical condition that can definitely rob a person of her ability to live life. Surgical diagnosis cannot be diagnosed by exam, history, blood or urine tests, x-rays, ultrasounds, MRI, CT. Surgeon has to look surgically, and in response or lack of response to medications does not rule in or rule out endometriosis. That's not new information. When a physician looks in the abdomen, they have a choice. They can destroy the lesions by superficially laser vaporization or electrical cautery, or they can do excision to completely remove the tissues that are hurting them. Superficial application of any of the wavelengths of laser or electrical energy only penetrates 2 millimeters into the tissues. That's been published and studied. The disease is already deeper than 2 millimeters in 61% of the cases, deeper than 5 millimeters, 25% of the cases. That is not disease coming back. And often the pain gets worse because you've applied energy to a chronic irritation of the disease that is still there and viable. Almost all centers that specialize in endometriosis in and out of the United States perform excision. I had a chance to check this because at MIT in October 2015, they got 40 of the top endometriosis surgeons in the world in one place, and I spoke to the people who have published a lot of the data. Excision gives the best chance for long-term pain relief and minimizes the need for repeat surgeries. Even when superficial treatments are done, they treat the lesions they see, and they do not do anything around the periphery. We know for a fact they can have perceived pain up to 28 millimeters beyond the visible border of a lesion. You've got it. This benign condition is locally invasive. You have to treat it from an oncology standpoint, and you have to take margins which are not done, which means all the comments that are made, you have to separate laparoscopic cautery from true wide field end block excision. We do not tell our people that they have to get pregnant within 6 months because we want them to be good, stay good, live happily ever after, and forget who I was. Endometrium is stimulated and supported by the hormone estrogen. The rationale for Lupron is that we could remove estrogen, the endometriosis would dry up and go away. Sometimes medical suppression will give some short-term pain relief. But the endometriosis and pain is still there when the patient comes off the medication. Why is that? That's because endometriosis can survive in low estrogen environments. It has the enzymes necessary that it can produce its own estrogen. It can feed itself. And your proof of the pudding is aromatase inhibitors. Why else would they be used? Most referral centers for endometriosis use excision. Most of these surgeons do not use Lupron suppression. It's expensive. It doesn't get rid of the problem. It has awful side effects, some of which are quite long-term. And it's not needed if you really did complete removal of the disease. Elagolix is an oral GnRH antagonist. Both Lupron and elagolix are anti-gonadotropins. Similar side effects can be expected. Secondary dysmenorrhea is menstrual pain due to a medical condition such as endometriosis, whereas, of course, primary dysmenorrhea is menstrual pain in the absence of underlying medical condition. It's because of primary dysmenorrhea that all young people with these symptoms should be given 3 to 6 months of oral contraceptives and anti-inflammatory medications.
Dr. Robbins, could you just...
I'll finish it now. If pain persists, then laparoscopy is the next step, not put on medications. Medications such as elagolix and Lupron should not be second-line therapy after oral contraceptives and anti-inflammatories because they have significant side effects and are not harmless. Thank you for your time. Any questions?
Our final public comment is from Heather Godon.
First, I'd like to thank the panel for the opportunity to be here. You know, they say, speak the truth even if your voice shakes. And so Casey and I are primarily here today to speak for those who have no voice. We cannot have this discussion without acknowledging that profits have been prioritized over patients by organizations and institutions that have for far too long shaped the educational treatment and funding protocols the rest of us must live with. It is no secret that the industry dedicates significant resources to attempts to shape the prescribing behavior of providers. leaving patients vulnerable and susceptible to poor treatments. The system isn't broken, they built it that way, and the time has come to fix it. Despite its vast prevalence and substantial societal burden, endometriosis remains one of the most puzzling and challenging diseases of our time. Few conditions are more fraught by persistent inaccuracies than endometriosis. And unfortunately, far too many are still entrenched in outdated notions which bolster such falsehoods as anecdotal diagnoses are acceptable, a concept actually rooted in very limited evidence, primarily and unsurprisingly by a single consensus, arrived at a panel comprised of several advisors to the pharmaceutical sponsor, and old wives' tales which provide ongoing justifications for non-excisional surgeries, medical suppression that may actually be of no benefit, and which does not modify disease mechanisms itself, potentially needless as directing and other various failed approaches to diagnosis and treatment. However, such premises are often mistakenly built on the assumption that all surgery is akin to medical suppression, that all surgical procedures are of the same type and performed by surgeons of a similar experience and skill. They are not. While such postulation allows for the belief that surgery simply doesn't work, it in fact overlooks the wide disparities that actually exist and ignore the excellent results achieved by skilled excisionist with adequate experience in disease recognition and resection every day. This is substantiated in the literature. Those with suspected endometriosis could benefit tremendously from timely referral to specialist centers for careful clinical assessments, appropriate investigation, and multidisciplinary care, not simply placed on yet another powerful medical therapy which can provide neither diagnosis nor necessarily effective treatment, a treatment which we keep hearing today, not enough evidence. Like all hormone therapies for endometriosis, GnRH analogs have their roots in male prostate cancer, not actually women's health. They are an expensive band-aid which do not historically improve symptoms beyond cessation of therapy, nor do they preserve fertility. We have been here before. I should know because I too am one of those patients who spent years mistreated with the then novel GnRH analog, which is touted much as elagolix is today. I did not really obtain any relief for my symptoms, but I did receive lasting side effects like memory loss, bone mineral density loss, and from which I had osteopenia of L5-Q8 before my 26th birthday. Don't take my word for it. Take the word of the more than 10,000 adverse events reports which have been filed with the FDA on Lupron. I am also one of the individuals who underwent multiple failed surgeries before finally finding relief and fertility restoration through the hands of an expert excisionist. I am not an outlier and my experience is not unique. These medications have made billions for their parent companies and for the executives, stockholders, and paid celebrities who promote their products to an uninformed, unsuspecting audience through primetime commercials, across social media, and through the organizations they partner with. They have, however, done little for people with endometriosis. One of the much heralded benefits of GnRH antagonists is a lack of clinical flare and a more tolerability, compliance, and less side effect panel. In one study, for which AbbVie itself was asked to review the safety and efficacy data, these side effects which were discussed were attributed as not the responsibility of the drug. Yet serious adverse effects were noted and still assumed not associated. This is an astounding finding considering that all GnRH analogs have historically been category X drugs. There is in fact a dearth of side effect profiles in the literature today specifically regarding elagolix. One of the first GnRH antagonists used for endometriosis, elagolix, was also determined to be effective in the treatment of pelvic pain caused by endometriosis. However, the side effects of that drug slowed the progress of its development. So the question begs, is elagolix really such a breakthrough, and are its benefits superior to existing therapies, and are side effects indeed more tolerable? I am not anti-pharma. I depend on and will for the rest of my life, and autoimmune drugs simply be able to sit here and function for you today. We are not asking for a moratorium on drug therapies or any therapy for endometriosis. We are simply asking for the decisions regarding their use to be made based on actual true evidence, integrity, and transparency. Science should not be for sale, and patients can never be. I make the plea to those voting today to remember the words of George Santayana, who said, "Those who cannot remember the past are condemned to repeat it." Thank you.
Thank you. We have just a minute for perhaps comments or questions for the CEPAC panel.
I hate to take for a minute. We have some few of them
advocates arguing against medication. You are correct. I just wanted to be clear.
And we're pretty desperate to feel better, right? We desperately want really good medications for ourselves and the next generation, but
You have to understand, these are the drugs that have failed.
I always appreciate the patient perspectives. They're so critical to our work. These really have been exceptionally helpful. So thank you for sharing that.
thank you.
That was our pleasure. Have there been, I'm sorry to understand, but sort of the more aggressive, less aggressive surgical therapies, have the more aggressive surgical therapies been compared to placebos or other types of treatments like Lupron and randomized controlled trials?
So as far as fertility, and pain control, it does seem that there is an advantage for patients that have stage 3-4 disease. Remember, we're talking about different diseases. There is definitely a significant pain improvement with excisional surgery and treatment of deeply infiltrating endometriosis. And there is also a fertility benefit that 30% of patients, depending on their presentation, will often conceive, sometimes more depending on the series. The problem is that often, it will grow back, and so even after expert excisional surgery, there is a recurrence risk, and that sort of, when you think about drugs, that may be a potential role for some kinds of hormonal or non.
We've heard about the fact that there are surgeons.
The quality of the surgical data, I looked at it, it's garbage.
How common is it to have
Oh shoot, my mic's on.
surgeons who are really knowledgeable about this disease and treatment, because availability of a drug that gives even some relief, if not perfect, may be something that people in rural areas that don't have access to a really good surgeon may benefit from.
Yeah, I think, and you can kind of share comments at this. At many centers, there's a person who is the referral person for a lot of these diseases, and there's varying quality to even that person. So it's hard to get, as the other physician said, in a room 40 people where this is what they live and breathe every day. And so I think there's varying results depending on the skill of the surgeon. And actually my concern with this medication is that this will be a temporizing measure used by people who don't have the skill to perform excision. Because I've seen that many times with Lupron. So I have a concern that it may actually be used in exactly the way that you mentioned and may prevent women from getting to the kind of surgery that they may need initially to be followed potentially by suppression.
Thank you. Can I just ask our panelists to turn their microphones off because we only have a certain number on? Thanks. Claudia.
Thank you for your comments. I very much appreciate your giving us the fuller picture. So I just want to ask a clarification of our specialists. Is where do you see the role of, let's say, I don't know whether we want to put elagolix and Lupron in the same group, or certainly Lupron in the armamentarium for the therapy for endometriosis right now?
Could I just interject for a second? Could we just reserve that question for the roundtable so we can get through the voting questions?
Well, my concern is that I think it might affect the way I vote.
Okay.
I'll try to be concise. So I think that there's endometriosis and there's endometriosis. And there is mild and moderate endometriosis that while there's minimal disease that's physically present, the pain experience is very high. There's been some really excellent studies at NIH and other locations that the severity of endometriosis does not correlate with the severity of the pain. And so there are patients that have minimal disease, have severe pain, that are effectively treated with birth control pills, with Lupron, with Mirena even, that reduces the amount of menstrual flow. So there are a number of things that treat the lesser disease. The disease that these ladies express so profoundly eloquently is not what everyone has. And I totally agree that there may be temporizing times where physicians don't recognize that, oh, this is somebody that is more severe and needs to have a more rapid trajectory to an excellent surgeon, which are very much regionalized. I've worked in Pittsburgh, I've worked in Richmond, Virginia, and here in Burlington. And the best physician I've seen in excising was in Pittsburgh. We didn't have we had some, but they weren't as skilled as the physicians in Pittsburgh. So that's variably accessible. So I think to your point, that's there as well. What I would do is if I could, we were talking, and if we could design any study we wanted, what we would want to see is the low dose elagolix compared to birth control pills in a head-to-head study, and the high dose elagolix compared to Lupron in a head-to-head study with severe endometriosis patients that had failed birth control and failed the easier, cheaper treatments that are there. And we don't see that, and so it's hard to say exactly. But I could see myself using this. I would be excited to have it. That's why I looked into participating in the trials, because I want to see. We need to know more. I want to see if it's going to work, because there's so many people that don't have the therapy.
Thank you. I think we should now transition to our voting and deliberation by the CEPAC panel.
Can I make one quick comment? I'm so sorry, I know you're trying to move it along. I do so appreciate the descriptions of what you have been through, and that echoes when you make it. But in thinking about this as you move to voting, I just do want to make it clear I'm a surgeon, but I'm also a reproductive endocrinologist. And from an endocrinologic standpoint, elagolix is not oral Lupron. The mechanism of action is actually completely different. And there are reasons to think that there may be a different side effect profile, including long-term data. So I just want to keep that in mind. I don't want to conflate the two.